Okay, so this is part 1 of our MSK series. This is going to be a talk on trauma, miscellaneous stuff. Okay, so first case. This is an anatomy case, but it's also applicable for a trauma case or pathologic fracture case. So I've got a bunch of different colored arrows here, and I am pointing to where muscles attach. So these questions can most easily be asked either what attaches here, or if it would show one of these pieces of bone actually pulled off, then it could be, what is this an avulsion of kind of deal. So let's go through them. Let's do this blue one first. So first let's discuss what is it. So this is, we've got two things here, one here and one here. This one's superior, so this is the anterior superior iliac spine, and superior starts with an S, and so does sartorius, so that's how I remember that. Now, the other one I'm going to remember basically as the other one is the other one. So if this one is superior, then this one is inferior, and that is where the rectus femoris attaches. Now down here, this is the thing that you sit on. This is your ischial tuberosity, and it's helpful to remember that you sit on it because it's helpful to remember that this is sort of posterior. So if this one's posterior, then this one up here is anterior. And what are the things that are posterior in the back of your leg? Those are your hamstrings, right? So that's how I remember that. Posterior part of the leg is the hamstrings. Thing you sit on is posterior. Now, here is the lesser trochanter, right? So, and the lesser trochanter has the iliopsoas, and I can sort of remember the picture in the anatomy book where the muscle is coming down all the way down and it's coming down onto here. If you remember that, sort of like that cartoon, Netter's cartoon. Or you can sort of remember this lesser ilio, like this LL thing here. Sometimes that's helpful. Maybe a way to remember that also. And then the other one, so if this is lesser, this is greater. And another thing that starts with a G is glutes. So greater trochanter glutes, ilio psoas, lesser ilio, lesser. It's not just all the glutes, though. It's which glutes? Because we've got three different glutes. Remember, there's maximus, medius, and minimus. So only two of the glutes attach here, and it's medius and minimus. Maximus actually attaches on this thing called the gluteal spine or the oblique ridge, which is further down. So what about this here? What is that pointing to? So this is right at the pubic symphysis, right? Get oriented here. And you can get tugging there. Some people call that like an athletic pubalgia. But this is the adductor magnus. And because if you would get shown an MR case that was directed right at that, that's pretty much the only thing they could possibly show there, like fluid, like undercutting up through that thing. Let's go back to this again one more time. And just because I believe in repetition is helpful for memory, I can run through these things real fast. So this was the anterior superior iliac spine, superior for sartorius. This is the inferior, and the other one is the other one, so that's the rectus femoris. It's the one I don't have a good way to remember. You sit on this thing, it's posterior. Ischial tuberosity is the thing that's in the back of the legs because it's in the back of your butt. That's the hamstrings. Ilio psoas on the lesser trochanter, the L for the L, and then the greaters for the glutes, right? Medius and minimus. So which one of these non-traumatic avulsion fractures is considered pathologic? So when I say non-traumatic avulsion, what kind of a scenario am I talking about? What I mean is something like grandma gets up from a seated position, has pain in her leg, goes in and gets x-rayed, and this thing's avulsed, or whatever. It was not a car wreck. It was not, Godzilla was not pulling on your leg. It wasn't a major trauma. So it's classically this one right here. So isolated avulsion fractures of the lesser trochanter are usually seen in adolescent athletes. It's rare in adults. So if the lesion is seen in an adult without a significant trauma, it's regarded as secondary to metastatic disease until proven otherwise. So that is the way it's described in the literature, and that's the way you should think about it. So in an adult without a significant trauma, it's a cancer. And I have seen cases of that in the real world. All right, so here's the next case, and the question is, you're doing an arthrogram. Which one of these do you stick the needle in? So red, yellow, blue, or orange. Where's your target? Now, some places you've done a million gazillion arthrograms, and this is a silly question, but there are other places where in the country where residents train where PAs or the fellows or somebody other than the resident does all the arthrograms, and you never have done one in all of training. So there are different techniques for this, but the correct answer is this. So a superior medial target is, generally speaking, where you will aim. Now, what is the typical cocktail for MRI? So you can do you can do basically 3 different injections into the shoulder, right? You can inject for an MRI, you can inject for a CT, or you can just inject for steroids for pain medicine. So when you're doing MRI, before it's not pre-mixed, or at least not where I trained. It's not pre-mixed. You have to mix it yourself. And again, this is, I don't want to hear people emailing comments and they're like, my institution, we use 1 cc different than whatever you just said. It's variable, but the general idea for the mix is the same, and that's the way that it's most likely to be tested. So volume is usually around 12 cc's. Your institution may use 11.5 or 12.5 or whatever. Most places use around 12. A little more than half of that is typically VisiPake or OmniPake or some kind of X-ray dye that will be opaque on the fluoro imaging. A little less than half of it is usually some kind of numbing medicine, lidocaine or xylocaine, some kind of cane. And then a very tiny amount is GAD, and this is most likely what would be asked in the question. Is it 1 cc of GAD? Is it 1,000 cc's of GAD? Is it 10 cc's of GAD? Is it 0.1 cc's of GAD, which is the right answer? So movement of the decibel, maybe some fuckery with, is it a liter or a milliliter versus, that kind of stuff. So 0.1 cc's of GAD. If you remember anything, that's what I would remember. Now, what about with CT? CT is done a little bit differently. You're not going to be putting GAD in there. The volume is about the same, but the way that people will do it is usually about 1-to-1 lidocaine and VisiPake is typically what is done. Now, is there a scenario where you might want to inject air? Is this ever a thing that you would want to do? So I'll step back and just think about it for a second. If you put air in the joint, So why do you put, let's say if you're doing an MRI, why do you put the VisiPake in the joint? What do you need that for? And the reason you do that is to confirm that you're in the joint, right? You want to see it go all the way around the joint. So that's the whole point of doing that. So if the person has a contrast allergy and you can't put the VisiPake in their joint, you can't confirm that it's in the joint. So you don't know if you're in or not. So that might be a scenario where you would put air in the joint, because air, you can see that there's air in the joint and that confirms your placement. But if you're going to do an MRI and you put a bunch of air in the joint, it's going to bloom and it's going to fuck up the MRI and you're not going to be able to interpret it correctly. So you would never put air in the joint if you were doing an MRI. Now, if you were doing a CT and they had a contrast allergy, well then there's no reason to even do the CT, because or do the CT with contrast anyway, because they can't get contrast. Why are you putting air in their joint? That's kind of silly too. So the only situation that I've encountered where you might put air in the joint is if you were doing a steroid injection and you wanted to confirm placement but they weren't getting imaged afterwards. So a therapeutic steroid injection, you can put air in the joint with your steroid cocktail that will confirm placement. They don't have to worry about the air messing up the MRI. If they had an allergy to GAD, you could just do a straight CT, or if they had some kind of contraindication, like if they had a pacemaker or some kind of aneurysm clip that wasn't MR compatible, or whatever, some kind of MR incompatibility, they've got metal in their eyes or something, you could just do a CT, right? But you would never put air in the joint and then image, especially not for MR. Okay, so what about if you're doing an arthrogram of the hip? Which is your target there? Well, the big thing you want to avoid when you do an arthrogram in the hip is by jamming the needle into the femoral artery. That would be bad, right? So MSK radiologists are usually pretty far removed on the spectrum from interventional radiologists, so they're not going to want to deal with a pseudoaneurysm. So you want to go as far away as possible. So you want that lateral head-neck target. And if you've ever done any of these are way easier to do than shoulders. You just come straight down on the bone. It's actually pretty hard to screw one of these up, other than by hitting the artery. So just stay on the other side. A lot of places, if you read the technical manuals, will say the first thing you do is palpate or Doppler the artery, take a magic marker and draw it on the skin so you know where that thing's at, and you could stay the hell away from it. Other people will just go on the far side and just assume they're nowhere near it. So what about the volume? We said that we do 12 in the shoulder. What about the hip? Hip's a little bit bigger than the shoulder, so most places will do around 14. The mixture is similar, where you're only using like 0.1 of GAD, and you're using like 3/4 or a little more than half of Visi or Omnipake and the rest lidocaine. So, do you remember what these things are? These are your forearm fracture types. So, Galeazzi is the fracture of the radius with a dislocation of the distal ulna. Monteja is the fracture of the ulna with a dislocation of the radial head. And the way that I keep that straight is I use the mnemonic MUGR. Monteja for ulna, Galeazzi for radius, MUGR, and the letter is for the thing that gets fractured, and the dislocation is the other one. So what about this thing? Fracture is here. It's not an eye test. What's that called? So some people will call that a gamekeeper's thumb. Other people will call it a skier's thumb. But what is actually pulling the fragment? This is a more interesting question. So the thing that's actually pulling the fragment is the ulnar collateral ligament of the thumb. So if you put your hand in anatomic position, you will realize that radius is on this side, right? And the ulna is on that side. So this is radial side. This is ulnar side. So that's the ulnar collateral ligament of the thumb. Now here's some trivia that you might need to know about gamekeepers' thumbs. About half of them have about 1/3 of them have the avulsion fragment. So 2/3 of the time they don't. 2/3 of the time they just have a ligament injury. And of course the ligament injury is the ulnar collateral ligament of the thumb. Now, speaking of that, what is this thing? What am I showing here? It's an association with this particular injury. You may have heard of this thing called a Stenner lesion, which is basically balled up, retracted UCL that's like pinned underneath of this adductor aponeurosis. And because it's there, it prevents contact of the UCL and the proximal phalanx. So who cares? You may or may not realize, if you've been in a cadaver lab recently, that a lot of these things that we call ligaments and tendons are different, but a lot of these things that call ligaments are just like fascial reflections that some anatomist has just named. Basically, if you rip one of these things and it lays back down, it will scar, and then it will basically reattach itself. Most people have torn their ATFL and their ankle. If you've ever inverted or rolled your ankle ever in your entire life, you've torn your ATFL probably. But yet, if you imaged it, it would still sort of look like it's there. It's just sort of like it looks thickened and stuff. So, it's been scarred. So they get torn away, and then they flop back down, and then they scar back down, and then that's basically what ends up happening. Well, if you get something pinned, this UCL is like lifted up underneath this aponeurosis. It can't contact with the bone, so it can't heal, and they have to actually go in there and intervene, so that changes management. And anytime something changes management, it suddenly becomes testable. Stenner lesion. Alright, so this is a classic this versus that. We're looking at the base of the 5th metatarsal here. So, what about this guy here? Is that a fracture? No. So, the way that I remember this is fractures are directed towards the joint. Okay? Fractures are directed towards the joint. Remember, you can have them sort of at different areas here, versus the aponeurosis, the apophysis, which is directed away from the joint. So, apophysis, away from the joint, apophysis, fractures go towards the joint. Speaking of fractures, so 3 different fractures here. They'd have names, and it's all based on distance from the base of the 5th metatarsal. So this first one is an avulsion. The next one is a Jones. He's the one in the middle. Jones is in the middle. And then the stress fracture is all the way on the end. So if this was a person, and his head was here, and his body was like this part would be superior, right? So this would be the superior part. It's the one that's the furthest away. All right? His Johnson would be in the middle. That's the one in the middle. And then the other one is the other one. Or you could say that his... Yeah, I was going to say the Johnson is the relationship of the Johnson to the asshole, but they're usually around the same level of the equator. So just think of the person, superior here, Johnson in the middle, and then the other one is the other one. So which of these is actually the most common fracture? Which one's the most common? When I was in med school and I was, training for step 1, those kinds of things, I had this humongous notebook that I had made full of most commons because I figured out that was a highly testable thing. What's the most common X? What's the most common Y? So what's the most common fracture at the base of the 5th? The avulsion is actually the most common. And the way to remember that is A comes first in the alphabet, so that's the first one, it's the most common. Now, what is actually an avulsion of? So let's review our anatomy here. So we've got different colored arrows. And just to orient you, this is the fibula here. Okay, so this is lateral. So we've got two lateral tendons, peroneus longus and peroneus brevis. And then we've got our medial tendons, and that is Tom, Dick, and Harry is the way that some anatomists will teach it. So the posterior tibial, the digitorum, and the hallucis. This one goes to the big toe. And I'm going to show you a way to think about this that will help you remember this, and you just remember that this one's the other one. The other one's the other one. So let's scroll through this, and we're going to watch. Now, what I want you to pay attention to is the relationship between Harry and Dick. So as we scroll, I was going the wrong way. Okay, scroll. Keep watching them. Right here. See this? They're going to cross. Because hallucis is going to the big toe, right? And digitorum is going to the other four toes. But if we go back to the beginning, notice that hallucis starts in the middle. He's got to get to the big toe, and these guys have got to get to the other toes. So they're gonna cross, right? So if you can remember that they do indeed cross, right about there, and cross. That is the knot of Henry. So that thing has a name. What is the knot of Henry? It's a Harry Dick. That's where Harry and Dick cross. Because Harry starts out on one side, Dick starts out on the other, and they have to go in different directions. Harry has to go to the big toe, and Dick has to go to the other four toes. So they cross. So if you can remember that relationship where they're crossing, then you can remember that Harry's in the middle, Dick's next to him, then they're going to end up crossing, and the posterior tibial is the other one, and that's all the way on the end. Alright, so now the whole point of this was to show you what lands on the fifth. So let's go back and we'll pick up our friends here. We've got longus and brevis on this side, the lateral side of the ankle. Now watch them go down. Watching. There was knot of Henry. Getting close, right there. So notice that longus is wrapping under the foot, and that brevis is attaching on the base of the fifth. So the answer to the question is peroneus brevis attaches to the base of the fifth. Now there's something else that attaches there too, which is the lateral cord of the plantar aponeurosis. I don't think that's what would get asked. I guess it could get asked. It's more likely that peroneus brevis would get asked. So how do these do? Do these do okay? Actually do crappy. There's non-union in like 50% of the cases with a closed treatment, so they'll often end up having to pin them. Speaking of that, what are these? So I got 3 cases. They are all the same thing in 3 different spots. So we're talking about that. So this is a stress fracture, right? Now notice that the stress fracture for the calcaneus always occurs in this direction. Could be here, but it always occurs sort of like that. It never goes in this plane. It's always sort of going against the grain like that. This is a so-called march fracture. People in the military or whatever that aren't used to going for long marches go for marches. And this is the navicular fracture that's always sort of right dead in the middle. It's always like right here, So you see a sclerotic line there some places. So which one is high risk? Which one's one? And I will go ahead and get to it here, which is this one. This one's high risk. Now, how do you remember that? Some people will call this the scaphoid bone, the navicular, and the wrist. So this is a navicular. So it's like the brother bone of the navicular or the scaphoid, and the wrist is the navicular and the foot. And just like the scaphoid is high risk for non-union in the wrist, the navicular is high risk for non-union in the ankle. So just think of them as like brother bones, like if you had 4 hands or 4 feet, like a dog or something. That's like the homunculus, the same bone. The same bone. Got it? All right, good. So moving on. All right, so again, with this high risk versus low risk stuff, so you can have fractures in 2 different places in the femoral neck, right? You can have a fracture here, and you can have a fracture here. Which one's good and which one's bad if you had to pick? So this is considered the good one because it's the compressive side. So the way that you bear your weight actually helps pin that fracture together. This over here is considered the bad side. It's the tensile side, where the way that you bear your weight actually pulls the fracture apart. Now, tensile sides are treated more aggressively. They're pinned immediately. And the compressive sides are treated conservatively, and they're not pinned until it's like 50% of the width of the femoral neck. What about in the tibia? Same deal there, right? So there's a good one, which is the posterior medial. That's, again, the compressive side. And then there's the bad one that's on the anterior side, and that's the tensile one. Some people will call that the dreaded black line. So if you're a runner and you get a stress fracture in your tibia, you want the one that's on the back side, not the one that's on the front side, because the one on the front side sort of opens up, and that has trouble healing. All right, so another case here. So this is a you tell me the history case. And then move it forward here. All right. And I'm going to move it back. So it's going to be a fracture, right? What I'm trying to show is that there's a little thing here, and there's a little thing here, and then there's a little bit more here, and then thickens even more, and then a fracture. So most of the time, when you see fractures in this part of the leg, they occur on this side. It's actually unusual to see it over here, and it's a classic look for bisphosphonate fracture. So that is the classic lateral cortical thickening that you see with bisphosphonates, and that heralds abnormal bone that's not strong as normal bone and prone to fracture. And you often will see this bilaterally, actually. All right, so what about these 3 things? So what I'm trying to show here is this guy, this right here, and it's easiest to see here on the MR. So this is the one in the navicular is Kolar's, that flattened second metatarsal head, that's Freeberg and fraction. And this last one here in the capitellum is Panner's. So all 3 of these are in the same family, and they are in a family of a whole bunch of different things that have names. Anything that has a name like this automatically becomes testable. So these are your osteochondroses. So basically, thing to know about this is that these are things that affect bones that are growing. It's only seen in children and adolescents who have bones that are growing. You're not going to see this in an adult or somebody who's finished growing, okay? So it's a peds thing. It's only seen in growing bones. So let's go through this list and see if you can remember all these things. So Perthes, you remember that's the femoral head. Freeberg, we said that was the second metatarsal head. Kainbach, that's the lunate, right? And that's associated with ulnar negative variance. Osgood-Schlatter, remember that is tibial tuberosity. Panner's, we just said, is the capitellum. Sievers is the calcaneus, the so-called growing pain. And then Sinding, Larson, Johansson is the bottom part of the patella. So let's talk about the trivia that's worth knowing about at least these three entities. So the first one, colars, this one's self-limiting. It happens more in men. I can remember that because I knew a guy I went to residency with had this when he was a kid, and he happened to be a guy, so I just remembered that was more common in men. Not sure if that helps you or not. Kolar sort of sounds like a man's name, right? So maybe that's helpful. It's self-limiting. He didn't have to have anything done. It just got better on its own. Most of these things are. An exception is Freeberg, which occurs more in adolescent girls. And there's one proposed mechanism that this happens because of high-heeled shoe wearing as a possible causative factor. So it tends to happen a little bit older when girls are wearing high-heeled shoes. And because there's something actually like creating that problem or causing that problem, I remember that means that it can lead to a secondary osteoarthritis. Panner's is seen in young kids that are like little league players often. You can have osteochondritis dissecans that occurs in the same spot, the capitellum, and it occurs in the same age group, and also occurs in throwers. The difference is that Panner's does not have loose bodies. So that's the thing to remember about it. It's just, it's basically just AVN. All right, next case, this versus that. So anytime you're getting shown a lateral view of the ankle, this is the first thing. So the first thing, here's my checklist for multiple choice. Stress fracture, calcaneus, okay. Thickened soft tissue here. If it's super thick, you can think giantism. If it's just a little bit thick, maybe they're trying to get you to say plantar fasciitis, though. If I was going to show you plantar fasciitis, it would be on an ultrasound case with calipers on here, or it would be an MR with edema here. The third thing, which is way more likely, is this kind of stuff where you've got coalitions. So this one versus that one. So calcaneus to the navicular, calcaneal navicular versus talus to the calcaneus, talocalcaneal. Now, let's talk about what some of the associations are. There's two main ones that you need to know. One is a flat foot, and the other one is a so-called talar beak. So if you see a talar beak and a flat foot, then you really need to think about coalition. So how often is it bilateral? Often enough. Men versus women? Way more common in men. A coalition seems like people who work in a coal mine, coalition, and guys typically work in coal mines more than girls. So let's go through some trivia here. What are they best seen on? So I will tell you that the talocalcaneal is that continuous C sign that I showed, and that is actually best seen on the lateral view, which is how I showed it. The calcaneal navicular is that anterior process, or so-called anteater, and that's actually easier to see on the oblique view, sort of like this, that thing. As opposed to the continuous C, which is seen best on the lateral view. Some people will call this an absent middle facet sign. The next thing is which facet. So the calcaneal navicular is that anterior process, and the talar calcaneal is the middle facet. That's the big one. So there is a posterior facet, but it's not involved in these. All right, so if I show you that, what is the next step? So you're shown this. What are you going to include in your dictation, or what are you going to tell them to do next? Let's get an x-ray higher up on the leg, right? So this is the maisonneuve fracture. It's a fracture that rides the interosseous membrane. So if they show you, so they can play this either way. They can show you proximal fibular fracture and ask for the ankle, or they can show you the ankle and ask for the proximal fibular fracture. So the gamesmanship can work either way with that, but this is a classic like first year call case where you're supposed to ask. Now you almost never have to ask because ortho knows this, and as soon as there's a fracture, then the ER who knows nothing calls ortho who does know some stuff, and ortho knows to order the second part of that x-ray series. All right, next case. This probably should have been in my nodules lecture, but it's this thing here, that thing there. What's that? Is that a tumor? Do we need to get or orthopedic oncology involved? Now this is a normal variant, right? This is a so-called avian spur or a supracondylar process. The one thing that is worth knowing is that you can have compression of the median nerve via the ligament of Struthers. That sounds like obscure trivia, and it is, but that is a thing that can happen there. The other thing that can happen with this thing is that it can get fractured, but that's pretty rare too. Or it can do nothing and confuse people who don't know anything. Alright, so I'll orient you here. Notice that we are at the level of the femoral head, right here, and what we've got is a big fluid collection sort of lateral to the trochanter. So this is a classic location for a classic injury. The other location for this thing is on the lateral aspect of the knee, depending on the sport you're playing. So in this case, along the trochanter, this person is a rugby player. Along the lateral aspect of the knee is seen in wrestlers. So two warrior sports, both of which are prone to getting this lesion, which ironically has a French-sounding name, which is sort of the opposite of being a warrior. This is a Morel-Lavallée lesion, and what it is a shearing component. So basically your skin is sheared, and you've got a potential space that is created, and that can fill up with blood and lymph, and these are actually a pain in the ass to get rid of, because if you would aspirate that out, they tend to come right back because there's this potential pocket. So they will end up having to put hypertonic saline or talc or something in there to sort of basically pleurodesis it down to make it so it goes away. But that's not your problem. It is your problem to recognize. So if you see a fluid collection like this along the greater trochanter or on the lateral aspect of the knee, and someone who partakes in combat sports, then you're dealing with the Morel-Lavallée lesion. Okay, so that is the end of part 1, and part 2 is going to be a talk on arthritis, multiple choice arthritis trivia.